Opioid Theory Part 2 of 2. This video aims to give you opioid facts to help your term. The opioid practice videos will give you examples to put these facts into practice. We will pick up where we left off in Part 1, talking about opioid switching. When switching from immediate release opioid to oral slow release opioid, give the last immediate release dose at the same time as the first slow release dose, so that there is some cover for the patient until the slow-release medication starts to build up in the plasma. When switching from oral slow-release opioid to immediate-release opioid, the first dose of the immediate-release opioid is given when the next dose of slow-release opioid was due without overlap, with PRN immediate-release opioid used in the meantime. When switching from a fentanyl patch to regular Q4-hour immediate-release opioid, there is still a reservoir of fentanyl in the patient's skin that is slowly trickling into the bloodstream. So start the regular immediate-release opioid 12 hours after the fentanyl patch has been removed. When converting the other way around, overlap the regular immediate-release opioid for 12 hours of effect to allow time for the fentanyl patch to start working adequately. When switching from one opioid to another, consider a 25% dose reduction due to variable sensitivity of an individual to different opioids. This is particularly the case if there were concerns of side effects with the original opioid or if it was felt the original opioid was not working. This issue is one where there is variation in practice amongst different doctors, so you may not always observe this due to the individual physician's discretion. However, we would generally like you to practice doing 25% dose reductions when performing your calculations when switching from one opioid to another to err on the side of safety. When converting from drug A to drug B, first convert from drug A over 24 hours to oral morphine over 24 hours, then convert to drug B over 24 hours. This may seem like an extra step, but it's standard practice to do it this way and allows people to check each other's work. When converting between opioids, always do your calculations with another person checking your maths. Even senior clinicians can make mistakes due to human error. Best practice is to document in the notes the maths you used to come up with your dosing, just like you used to write your working out during your high school maths exams. In the opioid practice videos, we will show you how we would like the working out to look like. When choosing the PRN opioid for breakthrough pain or dyspnea, it should be 1/12 to 1/6 of the total daily dose. For instance, if the patient is on MS-Contin 30 mg BD, use PRN Ordine 5 to 10 mg every 2 hours, maximum 60 mg per day for pain or dyspnea. In case you're not sure why we've chosen Ordine, Ordine is a common short-acting form of morphine, and MS-Contin is long-acting morphine, so you try to keep the same drug. Generally, the 5 mg dose would be used for dyspnea, and the 5 to 10 mg dose would be used for pain, and the maximum dose is 6 times the PRN dose. If the regular dose is increased, the PRN dose should also be increased, keeping that 1/12 to 1/6 ratio. Very common opioid side effects include constipation, nausea and vomiting, sleepiness or grogginess, and dry mouth. Regarding constipation, after checking current bowel habit, a starting guide is Caloxyl and Senna 2 tablets at night prophylaxis if newly starting opioids and not already on laxatives. Nausea and vomiting usually resolves after a few days, but make sure there is PRN antiemetic available, particularly for those first few days. Mild sleepiness and grogginess often wears off after a few days after a dose initiation or change, but particularly at higher doses can persist. Less common opioid side effects include delirium and hallucinations. Opioid toxicity occurs when the dose is too high for a patient. Opioid toxicity is dose-dependent rather than an idiosyncratic side effect. Symptoms include decreasing respiratory rate from baseline, reduced rousability and sedation, and myoclonus, which is spontaneous twitching and jerking. Late and serious signs include respiratory depression less than 8 breaths per minute, low oxygen saturations, and central cyanosis. Pupil size is actually not a reliable guide to opioid toxicity and therefore only plays a very minor part of the assessment. However, the symptoms and signs of opioid toxicity commonly occur for other reasons too, and it's a common pitfall to jump to the conclusion that it is opioid toxicity and miss something else. If a patient has been on a stable dose of opioid and is becoming sedated, it is unlikely to be due to the opioid unless a patient on morphine has developed renal failure or has had a medication error. Consider sepsis, renal failure, hepatic failure, hyperglycemia, hypercalcemia, an intracranial event, disease progression, or if the patient is simply reaching the final dying phase. These following management guidelines relate to palliative care patients, not acute post-surgical management, which is a different setting. Clinical suspicion of mild opioid toxicity is if the patient has a lower than baseline respiratory rate but still greater than 8 breaths per minute, is drowsy but easily rousable, and not centrally cyanosed. Omit the next regular dose, immediately discuss with palliative care, and inform the in-charge registered nurse. Most likely management will involve waiting for some of these symptoms and signs to resolve and reducing the ongoing regular opioid dose. Naloxone is not required. Severe opioid toxicity requiring naloxone is rare. Clinical suspicion is if the respiratory rate is less than 8 breaths per minute, and if some of the following are also present. The patient is drowsy or unrousable, oxygen saturation is less than 85%, or the patient is centrally cyanosed. This is a code blue if in keeping with the documented ceiling of care. Administer high-flow oxygen, omit the next regular dose, and immediately discuss with palliative care and inform the in-charge registered nurse. In this situation, we should aim to reverse the opioid at least enough for them to breathe properly and be rousable. We don't need complete reversal. Likely management will involve an IV cannula, although naloxone can be given intramuscularly or subcutaneous if required, and dilute a 1 ml 400 microgram naloxone ampule with 9 ml of normal saline in a 10 ml syringe. Then administer 1 ml of the diluted solution IV, which is 40 micrograms naloxone, and monitor for response. Titrate every couple of minutes with further 1 ml doses until effects of respiratory depression are reversed enough that respiratory rate is above 8, oxygen saturations are normalized, and patient is rousable but does not need to be wide awake. If the situation is extremely urgent, 2.5 ml doses of the diluted solution, which is 100 micrograms, can be given instead. Use normal saline to flush in between increments, and once symptoms and signs have improved, the patient will need ongoing close monitoring that they do not relapse back into respiratory depression. Note how we do not use an entire undiluted ampule as a stat dose. This could lead to severe pain, which would not be responsive anymore to opioids until the naloxone has worn off. Patients will usually respond to 2 to 4 ml, that's 80 to 160 micrograms, of diluted naloxone with deeper breathing and improved level of consciousness. If there is little or no response to naloxone, consider other causes again other than opioid toxicity. Finally, if it is opioid toxicity and naloxone works, further naloxone doses or a naloxone infusion may be required as the naloxone wears out, because the duration of action of many opioids will exceed that of naloxone, which has a duration of action of 15 to 90 minutes. This is particularly for opioids with a very long half-life, or where impaired liver or renal function is slowing the clearance of the opioid. The next lessons are opioid practice videos, so please have some scrap paper, a pen, and a calculator ready. This slide shows key references. Appendix for registrars entering palliative care advanced training. This slide shows examples of different opioid conversion ratios used amongst different palliative care specialists in Sydney. The column titled SESLHD shows the ratios we use in our local health district, and the other columns show some examples of ratios used elsewhere. As default, we would use the ratios used in SESLHD, but I do find it useful to look at some of the other ratios possible. It can give me a sense of where the ratio I am using fits in the range of commonly used ratios, and sometimes it also gives me a sense if I should be rounding up or rounding down to a particular tablet or patch strength. See you next lesson.